We tried to see if BRAF drugs, targeting agents, would work in BRAF-mutated colon cancer. Same mutation as in melanoma, so the hope was this would work the same way, but it didn't. Really had very little activity as monotherapy, and it really took some clever clinical trial designs and thinking to actually demonstrate how best to bring BRAF inhibitors to the world of colon cancer. Scott Kopetz down at MD Anderson is really one of our major thought leaders in driving positive clinical trials forward, incorporating targeted agents in a logical way. And he led the SWOG study, really taking BRAF mutated patients and enrolling them into a randomized clinical trial. It was a debate whether or not if you just had a BRAF mutation, do the EGFR drugs work or not? Because most of us thought they would be resistant. And so it was a doublet combination of irinotecan and cetuximab, which would be sort of the standard of care, versus a 3-drug combination of cetuximab, irinotecan with vemurafenib added. And this randomized clinical trial, just a small clinical trial actually, first accrued very quickly, which meant that there were a lot of BRAF mutated patients who were hanging out there looking for options. So even though not a common mutation, it's common enough that this became a patient problem. So it accrued very quickly. And the findings of the clinical trial are incredibly important, even for a small phase 2 randomized study. It demonstrated an improved response rate and progression-free survival and a trend towards improvement in overall survival from the 3-drug combination. And it showed that there really wasn't very much benefit in BRAF mutated patients from the 2-drug combination of cetuximab and irinotecan by itself. Now, much to everyone's surprise, I guess except the people who are on the committee, NCCN guidelines actually adopted that study as enough evidence to go forward with that. And so while I'm happy about that, because if I was a patient with a BRAF mutation, I would want access to vemurafenib in that setting based on this clinical trial. But how it sort of shot ourselves in the foot is that we now have struggled with accruing any new clinical trials to try and understand how to move that bar forward. And so we need to keep pushing this forward as we attack this pathway. Why would you combine drugs? If we really think BRAF is the driving mutation, why didn't it work by itself? Well, we know that the signaling pathways in metastatic colon cancer are actually complex. And so if you block one, there's roots that kind of take it around. RAS and BRAF are actually in the same pathway. And so the logic here was that if you hit the pathway twice, that you would in fact have an improved outcome. And there's theory and preclinical data that supported this. And what's great is that the clinical trial really demonstrated that that theory was true, and that by hitting this pathway in 2 places, you then uncovered clinical activity that before we didn't get. If you're thinking about using targeted therapy in colon cancer, you have to know the BRAF status. If you find a patient who has a BRAF V600E mutation, that's the patient where this triplet therapy may be best played. Usually that would be in the refractory setting, and NCCN guidelines now give us permission. These are all approved drugs. Be careful and watch the toxicity. 3 drugs are harder than 2. There is no question that's true, but not unmanageable. The oral medicine vemurafenib has its own issues. The cetuximab or panitumumab have their issues with mostly skin rash, can have diarrhea. So you need to do good skin rash management. You need to watch for the GI toxicities and the like, and skin toxicities as you set forward. So when you set off on this 3-drug regimen, don't think it'll just be a piece of cake. Watch your patients closely. BEACON
study is a phase 3 study in a patient with BRAF mutant tumor that failed 1 or 2 lines of chemotherapy. It actually has 3 arms. One is combining a BRAF inhibitor, the encorafenib, plus a MEK inhibitor, binimetinib, plus a EGFR drug, cetuximab. The second arm is a combination of cetuximab plus a BRAF inhibitor, and the third arm is a control arm of using chemotherapy with either FOLFIRI or irinotecan plus cetuximab. The primary endpoint of the study is overall survival. Now, the rationale behind is very clear. We know that patient with BRAF mutant tumor tends to have activation of the RAS, MEK, and the MAP kinase pathway. Now, in other diseases, if you block the BRAF and the MEK inhibitor, it seems to be a very durable response with improvement over survival. However, in colon cancer, that is not true due to the feedback activation of EGFR. So in order to overcome the resistance, you have to probably add an anti-EGFR drug on top of those doublets to overcome the resistance. So that's the rationale behind the BEACON study. Now, the early 30 patients run-in data was presented at GI ESMO by Dr. Van Cutsem this year. Now, the result seems to be very promising. Now, the triplet regimen of the BRAF inhibitor plus a MEK inhibitor plus cetuximab showed a response rate of close to 48%. Now, in patients who failed only one line of chemotherapy, the response rate was high as 62%. And the PFS was, I believe, was around 8 months, and the median overall survival was not reached at the time of the presentation. In terms of the toxicity profile, in terms of the most common grade 3-4 adverse event that occurred more than 10% of the time was fatigue and anemia. To my surprise, the rash was not an issue. There was only one patient that developed grade 3 rash. In BRAF mutant tumors, after they fail the first-line therapy such as FOLFIRINOX plus bevacizumab, it is definitely reasonable to try to use the BRAF inhibitor plus an EGFR drug. Now, based on the study, the SWOG 1406 study, there was a trial comparing irinotecan plus cetuximab plus minus a BRAF inhibitor. And the study was very consistent with the BEACON study, the running BEACON study, where it shows that there was improvement in overall survival, improvement in response rate, and improvement in PFS by adding a BRAF inhibitor to irinotecan and cetuximab. Therefore, in the patients who fail first-line therapy, if I could get a BRAF inhibitor off-label, that's what I will try to do. And it is also on the NCCN guideline as well as part of the companion listing.